Good morning to most of you and good afternoon from me here in Ho Chi Minh City, Vietnam. And thank you, Pantelis, for that introduction. As Pantelis said, I'm going to be talking really about some of the work we've been doing in Vietnam that's been addressing what we think are some of the big challenges for low middle income country healthcare systems and introducing technologies to try and do that. Just a little bit of background for those of you who are not familiar with Vietnam and OCRU itself. I have been based in Ho Chi Minh City for quite a few years now. My background is a clinician practicing in critical care. And I've been working at the Oxford University Clinical Research Unit on a variety of clinical research projects, but essentially looking after very sick patients. The Oxford University Clinical Research Unit has been in Ho Chi Minh City since about 1991. Its remit is very simple. It's to work on locally relevant diseases and produce globally impactful research. We're hosted by a government hospital, a large government hospital called the Hospital for Tropical Diseases. But now work really throughout Vietnam and the region, including Indonesia and Nepal, in both hospital and community settings. So in terms of low middle income country healthcare system, it's just worth reminding ourselves that most of the world's population live in low and middle income countries. And in 2018, the Lancet Commission produced a report on quality of healthcare within these healthcare systems. And this kind of astounding figure really that about 8.5 to 9 million people each year die because of poor quality healthcare within these systems. So not even lack of available care, but poor quality care. And that accounts for up to about 15% of deaths in these countries. And as a result, the Lancet Commission really argued that providing any kind of healthcare without ensuring high quality is unethical and shouldn't be done. It's of course expensive. So all of these deaths and morbidity associated with poor quality care cost an estimated $1.5 trillion every year in low middle income countries. And even in high income countries, a significant proportion of healthcare costs are associated with poor quality care. The World Bank has just produced a report that shows that improving quality of care is also cost effective. And I guess finally, we should remember that the Sustainable Development Goal, we all talk about access to universal healthcare coverage, but that also includes high quality essential health services. So if we're talking about quality of care, what do we mean? Well, there's growing consensus that there are various components to define high quality healthcare. So on the left is how WHO look at it. So high quality healthcare should be effective, means that it should be evidence-based treatment provided. It should be safe, and we shouldn't be harming our patients. It should be people-centered, providing what they need, and of course timely, making sure that emergency care is there when it's available and unnecessary delay is avoided. It must be equitable, so that means irrespective of geography, race, gender, socioeconomic class, everybody should have access to high quality care. And of course, it should be integrated throughout life and with other healthcare services and efficient and avoid waste. But I think Pantelis has already highlighted very nicely some of the particular challenges in low middle income country settings. And I just want to kind of emphasize that these settings are also very diverse, and we should always remember that, both between countries and within countries. So on the right are a couple of pictures from Vietnam. One is a typical outpatients clinic, very, very busy. This is pre-COVID. Many patients arriving, wanting to see a relatively small number of doctors. And then the flip side on the other picture is a rural health clinic, very remote, and not enough people coming there for treatment. And then in addition to these kind of constraints on resources, we have to remember that the operating environment of many of these clinics and healthcare services is very difficult. Often it may be power cuts, we've got extreme temperature, natural disasters to deal with as well. Improving quality of healthcare, though, is not easy. There are many, many examples that just providing equipment, ensuring that its distribution is geographically equitable, or giving out guidelines doesn't make any difference. And I think also, it's really nice to hear your introduction, Pantelis. I think, remember that just taking something that works in a high-income context and expecting it to work in a lower middle-income country doesn't always work either. I put on the right something, I think a very salient example in the terms of medical research. This was done, luckily studied very carefully by a team led by Kath Maitland in Africa, and that was what was thought then to be a very standard, simple therapy for children, giving them fluids when they had severe infections, actually, when carefully studied in an African context, actually caused significant problems and increased deaths in children. So we have to remember, we need to consider always the context. So my particular interest is critical care. And about 2 years ago, we brought together a lot of other critical care doctors from the region, South and Southeast Asia, to try and define really what they thought were the real barriers to producing high quality care in the ICUs. And they came up with things that perhaps we would expect based on the introduction and what I've said before. So access, very important. Cost of treatment. I think it's worth remembering that in these settings that a lot of patients have to pay for treatment themselves. Cost of critical care anywhere is expensive, and its relative cost in low middle income countries is no different. And in fact, we did a study in our hospital about 2 years ago where we showed approximately 50% of patients and families admitted to our ICU classified as having achieved catastrophic healthcare spending out of pocket directly because their relative was in ICU. Staff numbers and training is a big problem. I'll come back to that in a minute, but just remember that in a low middle income country, ICU, one nurse may have to look after 4, 5, 6, or even 8 patients compared to 1 or 2 in a high income setting. And that's really important because I think good monitoring is the cornerstone really of critical care, because we can detect problems early, we can intervene early. And so without it, you're already running behind. Equipment and infrastructure obviously is difficult if resources are constrained, but also remember maintaining equipment when you haven't got that backup that companies often provide in Western or high income settings is particularly difficult. And interestingly, a lot of our participants thought health systems themselves were not were barriers, partly because of the way they were constructed and partly because of particular ways that patients need to be referred through them to access the best care. So Vietnam in particular, I just thought I'd show you some more hard data really. We talked about overcrowding. On the left is a graph that is showing the government hospital bed availability in 2018 and then predicted in 2021 in the middle and 23 on the right. The lighter blue is how many beds are available, and then the darker blue is how many beds are needed and actually how many patients are admitted. And you can see, although encouragingly the light blue lines increase year on year, so does the demand for these beds. So supply and demand are out of balance and look to be continued to do so. And then on the right is the healthcare spending in Vietnam and compared to other countries in the region. So the blue lines is the actual healthcare spending in US dollars. So actually Vietnam isn't doing too badly, but the yellow line is the spending as a proportion of GDP. And you can see Vietnam's is the highest, which probably indicates, unfortunately, it doesn't have a lot of room to move in terms of increasing capacity using current models. And then similarly, these are doctor and nurse nurse numbers per 1,000 residents in Vietnam compared to similar countries. So we are quite low in terms of staffing and bed capacity. On the plus side, if we're thinking about using technology to deal with some of these challenges, Vietnam is in quite a good position, actually. The government have identified creating smart cities and smart healthcare systems as a priority over coming years, and have encouraged investment and policy in that direction over recent years, and particularly in investing in things like internet services. I think the other important thing is the Vietnamese population are particularly literate when it comes to using the internet and social media. So perhaps very happy to adopt newer technologies. So the challenges with critical care on the left, I think, are the ones that really we know exist. So having enough equipment to treat people, and also equipment to monitor people. A standard intensive care monitor cost between $15,000 and $20,000 each. We want to know what's wrong with patients. We want to detect if they're deteriorating quickly. So we do have to do frequent tests. That includes imaging. That's expensive. And of course, we need staff, a lot of them, to do these things, but more importantly, to interpret the results of these things. So I'm going to kind of focus now on a couple of areas of work of our larger vital project in Vietnam, addressing some of these. So we identified really the big problems to be, or the areas we might address were dealing with the monitoring and imaging and staff training. And this is the solution as proposed by us, and that we're working on essentially in these areas. So firstly, to get rid of the need for these big, expensive monitors, try lower cost monitors, for example, wearables, and similarly with imaging, particularly looking at using ultrasound because it's much cheaper and it's obviously portable. However, I think the really exciting thing is it's not just using lower cost, smaller equipment, it's actually then what we can now potentially do with the data from those systems, and how we can use machine learning and AI techniques to try and improve diagnosis management and feed into clinical decision support. So effectively, we're addressing some of the problems. So our approach here is looking at local partners and working with local partners, including the doctors and nurses, but also to really leverage what we would say is global expertise. And so we've got a large number of collaborators across the world, really. We have Imperial College, we have King's College London, we have the University of Melbourne, ETH in Zurich, all working together on this project. So I talked about monitoring and expensive monitoring being a problem. Well, a potential solution, which I'm sure loads of you are familiar with, are wearable devices. So they're obviously lower cost, and obviously they move with the patient. And that's a particular advantage, for example, in our intensive care unit, where we may have 28 beds, but we may have 34, 40 patients needing to be admitted at one time. And the picture's showing you an example of one of the wearable devices that we've been using. This is just a simple PPG or pulse oximeter connected to a wrist-worn device. That then connects to a mobile phone, and we're able to visualize that data either there and then or remotely access it. We're also using patch ECGs. And we've particularly chosen devices where we can get full waveform data from these, because we're very interested in that next stage of analysis and what we might do. So on the right, just showing you some results looking at ECG data in patients with tetanus who've been monitored on our intensive care unit using patch ECGs, but comparing that data with data from really high-end intensive care monitors. And we've been looking at heart rate variability data that we calculated from those, so quite sophisticated data. And the good news is that the kind of blue and pink, you won't be able to read it, is really small, but the blue and pink overlap, which is implying really that our data that we can get from these much more low-cost wearables is every bit as good as the high-end monitor data. And then the next stage, I guess, is what we can do with that. And this is, I think, from our point of view, the exciting part of the work, really. And that's starting looking at machine learning and building algorithms around these data. So this is some preliminary data done by one of our colleagues in Oxford, looking at ways of predicting whether patients with tetanus had mild or severe disease using these data from PPG and ECG. But I think the other issue in low and middle income countries is we're often dealing with different diseases to high income settings, and that means there aren't necessarily large data sets available if we want to do machine learning AI techniques on them. So David Clifton and his team in Oxford are working very much on ways of augmenting data and using that augmented data to improve our modeling and prediction. These are data actually from children with something called hand, foot and mouth disease. In most countries, that's not a big problem, but in Asia, a large number of children get it, and a small number of children who get it progress to really severe disease very rapidly, and spotting which of these children are progressing to severe disease is something that would be really helpful in terms of reducing demand on healthcare systems. So this is a work from, as I said, from Oxford, using GANs to do that. Examples of ultrasound in low and middle income countries are actually quite frequent now. It's attractive because it's low cost, it's available, it's safe, but as you can probably see from these images, that it's actually quite difficult to interpret, and therefore the role of AI, I think, is quite strong. Oops, sorry. And looking at ultrasound in critical care, we're particularly interested in it because obviously we can bring it to the bedside, and if you've got a very sick patient, that's a big advantage. But at the moment, it still demands a lot of expertise on behalf of the staff to perform the scans and interpret them. So our new approach is that we're using, I'm going to give you a couple of examples, moving towards firstly more automated systems, so you reduce the need on staff training, which we hope eventually we can also incorporate in into systems which are also more portable and lower cost. So we're working again on locally relevant diseases. So this is an example in dengue. And we're trying to use ultrasound of the lung to identify the occurrence of something called B lines. Why is it important? Well, B lines help us work out how much fluid a patient needs to be treated with. If we give them too much, it's very dangerous. So accurately assessing this is really helpful, but it's actually quite hard to do. So the team at King's, and particularly Hamideh Kidagari, have been looking at this, and she has been using an LSTM framework to analyze videos from patients with dengue and start to identify these B lines. I think she presented that quite recently. Some of you may have heard that at a recent meeting, showing that that's progressing really well. We're also interested in looking at the heart in critical care because it's one of the you know, it's the way we're pumping blood around the body. That's very important to us critical care doctors. And measuring something called the ejection fraction is really helpful. That tells us beat to beat how much blood is being pumped out of the heart. At the moment, that's quite difficult. You need to take a scan in a particular way, and you need to take measurements exactly by eye at the beginning and end of the contraction. Not surprisingly, other people are quite interested in that, and this EchoNet dynamic neural network has been developed by Stanford. But we've been working on it in Vietnam and again adapted it to our setting where we've been using it in dengue. I hope this is going to work for you actually, and maybe you can see some movement showing the heart pumping. But at the bottom, you can see that the ejection fraction from our adapted network automated measurement is more or less the same, if not the same, as those measured by experts. So our next stage is here really is that the automated measurement seems quite good. So now we need to help with guidance so that operators are able to put the probe on the chest in the right place to get the scan. I talked earlier briefly about the importance of wearables in terms of scalability and flexibility in overcrowded ICUs. I think the COVID pandemic has brought home to us throughout the world, this is actually an important thing everywhere. The graph on the right, maybe you can't read in clearly, but is a survey we did of the Asia Pacific region ICU surge capacity just at the beginning of COVID, so how much they could expand the ICU capacity. And actually there was very limited expansion capacity, and a lot of that was due to lack of equipment. So the nice thing we've been able to do, having had everything ready in this project, is use some of these wearables in the COVID pandemic. Actually, there's very little COVID in Vietnam, thank goodness, but we've been using the pulse oximeters that I showed you earlier in our hospital, in our field hospital, where patients with COVID are isolated. And we were able to put these wearables on patients who would normally just be monitored once or twice a day by a nurse who would have to put on full PPE to visit them. And patients had these wearables connected permanently. The nurses and staff could see that in the hospital, but even our staff in Ho Chi Minh City, a couple of hours drive away, could real-time monitor the patients. And again, because we're longer term interested in the signal quality, we actually started looking at the signal quality even from patients monitoring themselves in these conditions. And the data on the right is really just showing you that we were pretty happy with the quality that we were getting even from these low-cost wearables. So I think that's really talking about some of the technological solutions we've been looking at in Vietnam, and again, particularly around critical care. I think there are an awful lot of ongoing challenges, and most of you, if you're working in this area, know this very much. And so putting those thoughts into the framework proposed by the WHO, I've highlighted what I think really are the main challenges at the moment. Firstly, making sure that the solutions we're proposing are evidence-based and effective actually means we have to produce some good clinical trial data, and that's particularly challenging if we're looking at very low resource settings to use these in. Just having the infrastructure and capability to do good trials is difficult. Safety and ensuring regulation, again, is a big challenge. A lot of higher income countries are beginning to put in regulation for the use of algorithms in clinical decision support. But in most low middle income countries, that's still not the case. And that's very important if we want to ensure safe and high quality care. People-centeredness, I think, is very often neglected in lower middle income country settings. One of the really interesting things is when we put the wearables on the patients with COVID, is that they all reported afterwards that they were really happy and felt much better and much more connected being monitored in that way. However, we still have limited data on other settings and how acceptable using things like wearables could be to staff and patients. There is a danger that they're seen as cheap solutions rather than better solutions, and obviously that's not very popular if you're in one of these settings. A lot of low middle income countries have rapidly changing health informatics infrastructure. And it's important that we really understand that and particularly know where that's likely to be going in the future, to make sure that newer systems are going to be integrated. And again, that kind of links into efficiency and people-centeredness of them. And then finally, I've highlighted equity. I mean, I genuinely think that these solutions should improve equity, but there is a danger that they will actually widen inequity. They often rely on users being keen to adopt them. They often are going to be used first in better resource settings. And also, very importantly, there's a danger that we develop these devices on data from high-income countries, which actually is not going to be relevant or correct in low-middle-income countries. And we may end up back in a situation like the fluid study I showed you earlier on in this talk. So I think I'm coming to the end of the talk there. I'd like to say this is the work we're doing in Vietnam is work on behalf of a huge number of people in Vietnam and around the world. The Wellcome Trust are the major funder, and we're very grateful for that, but we get a lot of help from other institutions and organizations as well. So I will come to the end of my talk there. Thank you.